Okay. Although, oh, welcome to SF Live, excuse me.
Thank you.
So, although heart disease is actually the number one leading cause of death in the U.S., the percentage of deaths attributed to cancer is increasing steadily every year. So joining us today, we have research scientist Dr. Scarlett Gomez from the Northern California Cancer Center. And apparently it's the only center in the country dedicated solely to cancer prevention and research.
That's right.
And then we have surgeon and researcher Dr. Kim Rhoads from Stanford Hospital and School of Medicine. I have a question, and I guess either one of you could answer this, and that is, what is cancer disparity?
Well, I'll go ahead and take a crack, and then Dr. Rhoads can chime in.
Okay.
A cancer disparity is a disproportionate occurrence of cancer in a given population group, such as in a particular racial ethnic group. So we might see, for example, that one group, such as African Americans in this country, might have higher rates of some cancers than either the general population or compared to another population group.
I see.
And I guess what I would add to that is that disparity as a term in and of itself also applies to things other than just the simple incidence or the rates of cancer. So what we know is there are also disparities in how patients do after they've been treated for cancer. And those disparities that I'm referring to specifically, and I think that Dr. Gomez is referring to, specifically address racial and ethnic differences in outcome.
I see. And so would you say there is disparity? I'm pretty new to the whole thing, and so if you could, maybe elaborate a little more on that?
Well, there absolutely are disparities. One of the things we do at the Northern California Cancer Center, as you mentioned, we are the only center in the country dedicated solely to cancer prevention research, is that we operate our region's, the state-mandated population-based cancer registry. And what this means is that cancer registration is mandated by law. So there's a state law that anyone who sees somebody who's been diagnosed with cancer in their doctor's office is mandated by state law to report that to their registry. And we're the ones who operate the registry for the Greater Bay Area, 9 counties spanning from Marin to as far south as Monterey. And what the data that we've been collecting since the 70s, what that tells us and what that allows us to do is to track cancer across all geographic groups, across all socioeconomic groups, across all races and ethnicities. No group is left out. And so this is what allows us to track what's happening to cancer patterns over time. And what we've seen is that certainly cancer, absolutely, it does discriminate. It occurs, we know that African Americans, for example, are more likely to get cancers in general, and this is because they're more likely to get prostate, lung, and colon cancer. However, most cancer sites we know of vary across racial ethnic groups. Another example is breast cancer, where we know that non-Hispanic white women are much more likely than any other groups to get breast cancer. Asians are also at disproportionately high risk for certain types of cancer. We know that Asians and Vietnamese are more likely to get liver cancer, whereas Koreans and Japanese are more likely to get stomach cancer. One of the things that our data allow us to do, and that we're very active in doing at our center, is to try to enhance the cancer registry data that we collect to be able to monitor disparate and underserved groups more carefully. One of our biggest focuses is focusing on recent immigrants, and by being able to split up Asian groups in this way, we've recently shown, for example, that even though Asians as a whole are typically thought to have quite low rates of breast cancer compared to other racial ethnic groups, in fact, we find with our data that when you look at Asians who've been here for a long time, that their rates are as high, if not higher, than those of the general population, and in fact higher than those of whites.
Okay.
And again, I'll add sort of on the treatment side in terms of outcome disparity, what's interesting to note is that there are higher rates of most solid tumors in, for example, African American patients as compared to others, with the exception of breast cancer. And what's interesting about that is that despite the fact that the rates are lower in African American patients for breast cancer, their outcomes are worse after treatment.
Meaning they're more likely to
die.
To die, though.
Mm-hmm. And in general, the patterns, if you look in the national data, which is largely reflective of California data because there's such a large and complete cancer registry in California, what we see is that for tumors that tend to have a better outcome, tend to be more curable, that's where the larger disparities are by race.
Well, I'm not quite sure what you mean by that. That means that if they're cancer that could be curable, they're more, if you're, let's say, not black, you have more of a chance of surviving, is that?
Exactly.
And do you know the reason, or?
Well, that's,
I'm just curious.
It's multifactorial. I mean, I don't think it's, and I think that's actually why a program like this is really important, because there have been several explanations that have been put forth to try to figure out why the outcomes are different. I've been working in cancer disparities research probably since 1993 or 94, and I've seen sort of a migration in the conceptual frameworks around the explanations for why these disparities occur. And a lot of the literature really focused initially on the patient factors. So patients who are, for example, morbidly obese, or who smoke, or who have uncontrolled high blood pressure or diabetes are likely to have a worse outcome if they get cancer and get treated for cancer. And that inherently makes sense. But what they found was that those kinds of factors didn't completely explain the difference in outcome. So some of the next phases focused on clinical factors, sort of looking at whether or not the tumors were more aggressive, and several types of tumors are more aggressive in patients of color than in their white counterparts. In addition, minorities and patients who are poor or lack insurance tend to present at later stages, so the disease is more advanced. But now we're getting more into questions about socioeconomic status and the surrounding factors, the context in which the patient lives. And in addition to that, and sort of as an adjunct to that, the hospitals that the patients use, typically those in their neighborhoods, are coming into consideration for explaining these disparities as well.
So how do you go about cataloging all this, information, or gathering all this information?
Well, there are different ways that we go about doing that. An obvious first step within cancer research is this great resource that we have within our country, and which is the Cancer Registry. In the 70s, the federal government declared a war against cancer, and one of the results of that was federal money that is targeted towards the funding targeted towards setting up these cancer registries for enhancing surveillance of cancer. So what we do in the cancer registry, the data that we collect in the registry allows us to track patterns and trends in different population groups over time. One of the things that it also does is that it serves as a resource for researchers who want to contact patients, to interview them, and to collect additional information about their lifestyle factors, and perhaps link that to genetic information to understand this multifactorial nature of cancer that Dr. Rhoads alluded to, and trying to understand how all of these factors act together to increase or decrease rates of cancer, or poorer or better outcomes in certain population groups. And as Dr. Rhoads mentioned, I think a new generation of research that we're starting to get into is recognizing the role of our environment and the neighborhoods that we live in, and the institutions and the medical facilities that we're treated at, the doctors that we see, and how all of those interplay together to increase or decrease our odds of surviving from our cancer. One of the things that we have gotten active in researching and at the center is the social and the built and the institutional environment. And we have been collecting what we call geographic information systems data, GIS data that pinpoint where locations are, and data from the census, for example, that pinpoint, that tell us what are the characteristics of our neighborhoods. We've been getting messages for several years now that there is an obesity epidemic, and Dr. Rhoads mentioned that being morbidly obese and not engaged in physical activity does decrease your chances of surviving once you're diagnosed with cancer. It also increases your risk of getting certain cancers. But despite sending out the message, in the public health message that, we need to watch our diet, we need to exercise, we need to be physically fit, we need to reduce our weight, despite that, our overall Americans' weight has been increasing over time, and we think that part of that has to do with our neighborhood environment. Perhaps it's difficult